Heather's doing double duty today. She's both supporting in the background and been tapped on the shoulder to present. And it's such a pleasure to introduce Heather, who's my good colleague. She's the manager of programs and partnerships here at PGLO and has a long history of specialized geriatric services. Some of you working in the Champlain area may know her very well for her long career in that area. So Heather, I'm going to turn things over to you. Keep the chat going, keep the conversation going. And thank you again to Janine and to Christina who continued to answer questions in the chat, and of course to Stacy. So Heather, over to you.
Great. Yes, I'm now putting on my presentation hat, so hopefully I start to make sense and I'm focusing on risk assessment and not how to get into the learning portal. But we are working with you for those who are having difficulty. So bear with us throughout today as we get that sorted out. So it's so great to see everyone this morning. It's so fun to engage with those we're also passionate about providing the best possible care to our older adults. And as Kelly mentioned, I'm no stranger to specialized geriatric services, and it's great to see some familiar names. And so some of you have seen different iterations of this presentation before. I have been doing research in the area of risk assessment and management since about 2010. And happy to say we're just finishing up kind of a third study on this. So what I'm presenting today is, yes, from the literature, but also from some of the research I've done, and happy to review that. So where I'm going first is just starting with a primer on risk assessment and what it looks like. What are the components of a balanced and broadened approach to risk assessment? What are some challenges for us to be able to accomplish that? And then giving you one example of how we operationalize that approach with what I developed kind of to help us do that is the Living with Risk Decision Support approach. So in terms of objectives, hopefully by the end of the session, you'll be able to reflect on how your values and beliefs impact your current approaches to risk assessment, how to apply the elements required for a balanced and broadened approach to your current approach to risk assessment, and then evaluate how the 4 steps involved in the Living with Risk Decision Support approach could be integrated into your current practice. So before we dive into professionally how we assess and manage risk, it's always helpful to know personally what we think about risk. So here's where the fun part of the presentation, where I would love to see what have you done that others would consider risky, and please throw that into the chat. It's always such fun to see people's examples. And while people are throwing that, oh, thanks, Stacy, into the chat, I just want to give an example of here's what other people might think is the riskiest thing I've done, which is paragliding in Cape Town in South Africa. But what I consider the riskiest thing that I've done, and I know some people have seen me present on this, is this is a can of sweetened condensed milk. And then I'm pointing specifically to the lid. So while my husband would think that, you wash this liquid gold off in the sink, whereas I prefer to lick it off. And every time I do that, I always think like, oh my gosh, I'm going to slip my tongue. So I always feel that might be the riskiest thing I've done. And so we've got people who driving fast, riding dirt bikes, buying a house. Oh, Brittany, yes, in this political climate with no conditions. Oh my gosh. Anything else that people would say that maybe others would consider risky? Backpacking in Asia prior to cell service and GPS. Yes. Oh, Michelle, so risky, right? Um, so, but more importantly, what I want you to focus on is why did you take this risk, and throw that into the chat, even if you didn't sort of put what you've done that would others would consider risky. Why did you take this risk? Having fun, trying something new. Exactly. Took the risk for the reward. Yes. Closer to friends to prove to myself that I could do it. Exactly. It's fun. Yes. So what I'm going with here is thanks. Yes, exactly. Just a reminder that we take risks always, mostly always for the positive consequences of the risk. However, when we sort of intersect with the healthcare system, we're very kind of focused on the negative consequences. So, for instance, if I'm interacting with my financial advisor and they say, "Oh, what's your risk tolerance?" I'll say high risk, and then I get the statement that shows I've lost money. I mean, I didn't say high risk to lose money, right? I said high risk because I wanted to um, grow my money. So again, just thinking about why we personally take risks, I think helps us sort of orient us to all the decisions that we make. And then I now would like to move into kind of your professional beliefs, and I do have a poll for you. And there we go. So I want you to kind of agree or disagree with these statements. There's sort of, you can scroll down, there's sort of five statements. Do you agree or disagree with these statements? And great, thank you. So we almost have 100% agreement on all these statements. And this sort of beliefs, professional beliefs that we have about risk in our patients, is what is required to do a broad and balanced approach to risk assessment. So you're well on your way already to doing that. And so what makes it maybe a bit challenging for us to be able to kind of support that in our day-to-day work? So let's dive into, well, what does the literature say? So what we do know is as clinicians, though, we do have a tendency to define risk and living with risk negatively. We do have a tendency to define living with risk differently. We do have a tendency to focus on the negative consequences, and we do have a tendency to focus on the physical consequences. And so that's why, um, we're saying, what is the solution to kind of help us being skewed is what does a broadened and balanced and strength-based approach to risk assessment look like? And so the first one is how do we define risk? And when I ask, when we do these presentations in person and I ask you, how do you define risk? People use what's common in the dictionary, well, something dangerous or potential for something bad to happen. And certainly that is one part of the definition. But in order to support a broad and balanced approach to risk assessment, it's really understanding, oh, actually, and I'll just pull forward this statement, how often do you see the risks and benefits of X and Y? And so again, it subconsciously reinforces our definition that risk is only negative. But as I mentioned, this balanced approach to risk is defining it in a more neutral way, where yes, there are negative consequences, but going back to that first example of we take risks for the positive consequences. So a balanced and broadened approach to risk is acknowledging, yes, there are negative, but they're also positive. And are we acknowledging that in our conversations with our patients? And the other thing I just want to highlight here, risk always involves uncertainty. So the whether it's a positive or negative consequence has some sense of uncertainty. If we knew for sure, then it would no longer become a risk. And we'll come back to why that is important in a few slides. And so when we're talking about what does, that sentence we used before, what are the risks and benefits? What we're really trying to say is what are the harms of benefits of these kind of decisions? So again, trying to really, move risk as only negative, because why would we support people to live with risk if we only see risk as negative when we've clearly articulated what some positive consequences are? And so not only is a broad end approach to risk assessment acknowledging that they're both positive and negative, but as I said before, we're sort of skewed to kind of focus on the physical, but it's also acknowledging that there are emotional and social consequences as well. A balanced approach to risk assessment is acknowledging, yes, there are risks, physical, social, and emotional, to taking the risk, but also not taking the risk. And what that means is we're making decisions that acknowledge, like, what are the risks of returning home, but what are the risks of remaining in hospital? What are the physical consequences of returning home, but what are the emotional consequences of not returning home? So again, that is what the balanced approach is. And then when we talk about what are the positive consequences of taking a risk, is resilience. So by definition, we can only become resilient by taking a risk. And the research has shown where we've are a bit more risk averse society where we're sort of preventing kids from taking risk. And the research shows that that risk aversity is associated with increased depression, increased anxiety, and decreased resilience in children. And we're also seeing the same thing with older adults, where resilience in later life has been associated with decreased depression and increased quality of life. And again, think about our older adults who have had a lifetime experience of overcoming challenges, and how do we leverage, in a strength-based approach, some of the resilience that they've had a lifetime to develop. There we go. So here's, I just had my slides out of order. So here's what we're talking about. We're also having to kind of acknowledge that there are risks around taking the risk, but also not. So there is no risk-free option in terms of negative consequences. And I think sometimes when we feel that we're protecting people from harm, that is not possible, because there's always harm occurring, and the potential for harm that could occur with either the taking the decision or not taking the decision. A balanced and broad approach to risk assessment always involves shared decision making. So, for instance, as clinicians, we're again experts in the illness, the disease, the trajectory, what's causing the concerns, the resources. How do we make adaptations? And we're certainly very aware of what the negative consequences are. But as someone indicated in the chat earlier, in terms of, what is the reward for the client? So we cannot define what those positive consequences are for the client. It's based on their values, their beliefs, their goals, their dreams. So we require them at the table to really understand what they value and what they believe to be the positive consequences. Now, why is it hard? As we went back to, everyone has the professional beliefs required for a balanced and broadened approach. There are factors in all these areas that we'll just sort of highlight very quickly that make it difficult for us to support that balanced and broadened approach to risk. So first, as I mentioned earlier, alluded to earlier, is that we're living in what's called a more risk-averse society. And I think you can take full courses on Beck. So just to kind of simplify this concept, is that technology has made us more risk-averse. So think about way back when, before computers, and someone mentioned, hiking in Asia before GPS. When we didn't know something, so we're working in uncertainty, we didn't know, we would write a letter. It would take maybe 3 to 4 weeks to get wherever we thought the person had the answer. It would take them a few weeks to kind of get the answer, and then again another few weeks to respond. So we could be working in terms of uncertainty for 2 to 3 months. But fast forward to now, when we don't know something and we text somebody, Think about, if we don't see those three dots immediately, I mean, we can get our answers in seconds, minutes, hours, or even days. So if we were to think of working in uncertainty as a muscle, certainly we're not given that opportunity, to develop it. And so when we're working with risk, by definition, it's always in terms of uncertainty. And we are hardwired to perceive reward from uncertainty and discomfort from increasing levels of uncertainty. And with us working in this more risk averse society, we are also making decisions under more conditions of uncertainty in less than optimal circumstances with less than full information. As people have articulated sort of at the beginning, our cases are more complex, they're multifaceted and challenging. We're working with limited time and resources, and how that has an impact on that risk assessment process. And in fact, working in uncertainty, the literature talks about how that impairs our clinical decision-making skills. So we misperceive clinical goals of care. We have a greater vulnerability to what are called reasoning biases. So we sort of premature close our ideas of what we think is happening. We may make more unnecessary referrals when working under uncertainty. We have reduced engagement with colleagues and patients in decision making. And remember, a balanced approach to risk assessment requires that shared decision making. It has shown to lead to ineffective communication strategies and burnout. So again, already from just even a societal level, we have some strengthening to do around how we feel in terms of working in uncertainty. And certainly the goal is to promote curiosity over trying to get something 100% certain. And different sectors sort of hinder and enable our ability to do a comprehensive balanced, broadened approach to risk assessment. And so I know most of you are here from, the hospital environment, and certainly you can kind of add in what hinders and enables you to be able to do that. On the one hand, sort of in the hospital environment, you can do a whole assessment by the team. You can get access to, assessment to get more certain about what is happening. But you're also assessing an unfamiliar environment and with new illnesses. And certainly in the emergency department, there's still an unknown sort of trajectory. We certainly discharge people while they're still recovering. So understanding that. But, the negative feedback loop gets reinforced. So for instance, you may be concerned about someone and you discharge them home and they come back and you sort of reinforces this like, see, that didn't work. But what you're not seeing is maybe the 9 other people that aren't returning back to the hospital and maybe marginally managing, but certainly at home. In the community, you certainly have the proof of what is possible. Most of my career has been working in the community. I would come upon these situations and walk into a home and sort of look around, be overwhelmed, and sort of say, how did this person even, wake up today? I would refer them urgently to our Jarrett psychiatry outreach team, and they would support this person in this environment and situation for over a year. So again, they sort of showed me what is possible, even with sort of limited support. And then, long-term care, certainly they are really good at ensuring that we're aligning care to the values and goals and preferences of the residents. But again, it's a highly legislated, regulated environment that sort of hinders their ability to kind of also support some of these decisions. There are always multiple perspectives, as you can imagine. If you think about, if you were to label which client you would say is living with risk, who comes to mind? There's often, between the client, the clinician, and the caregiver, different focus and priorities. Even within families, there's different priorities and dynamics. People have different tipping points and thresholds, so there's no kind of one size fits all. It requires you navigating very difficult conversations and holding space for that around what are priorities for the patient and their family, which may be very different. What we also know is that goals of care differ when there are safety concerns. So everybody's coming to the table with very different expectations. And again, as I mentioned in the previous slide, we're having to navigate these conversations. And the other thing, if we're now zooming into smaller and in those multiple kind of circles, now we're with clinicians. We actually all perceive risk differently, which was a surprise for me in the first study that I did, where some clinicians were calling, the risky situation was related to impairments. Some people were relating it to the person's personality or values and beliefs. Others were calling it was the environment that was risky. Other people were describing the quote unquote event. So maybe falls or malnutrition or medication mismanagement as what the concern was. And then other people were worried about the outcomes, certainly the physical harm that could result or readmission to hospital. And so when people are having or teams are having these discussions around risk assessment and management, it's quite possible that everybody is thinking about something different. And I've had teams describe these care conferences as being kind of these swirling conversations that sort of never really get anywhere, is because actually people are talking about something very different. So again, as we'll show in the Living with Risk Decision Support approach, we really try to get people to be on the same page as what exactly are you concerned about? The other thing as clinicians that why this might make us hard is that risk is perceived and acted upon in two fundamental ways. One is feelings and one is analysis. And when we predominantly kind of analyze and act on risk as the feelings, which is that instinct, that gut feeling. And while using our instinct may have served us as a great coping strategy before, it actually skews us to perceiving that and amplifying the estimate of the risk. So, for example, those negative emotions we feel, the worry that we feel around our client, we will, if we were to say, and I try to illustrate this with this diagram that's kind of a work in progress, but what I'm trying to say here is that if we were to say the positive consequence is the same equidistance as the negative consequence, the emotion that we attach to the negative consequences is amplified by 3. So we perceive it to be more intense than actually, the positive. So what we tend to do then is over focus then on the feared impact, and we tend to judge the benefit as low and the harms as high, even when theoretically they might be equidistant. And the other thing I want to talk about is like, how do our values sort of creep into how we do our risk assessment? And just have our last poll here. And what I want you to do is, what would you prioritize? And I'm simplifying these. I know it's more complicated, but going for a walk, and this is someone with dementia, what would you prioritize for this individual? The risk of injuries from getting lost, or the risk of emotional consequences of boredom and frustration. And a walker use, the client is declining using a walker. So what would you prioritize? The risk of injury from falling versus the emotional consequences of being seen as old. And then discharge destination, what would you prioritize? Great. We almost got all of you participating here. Thank you. So, what I love seeing here is there is no right or wrong answer. So, what I love seeing though is just, we have in the first question, half of you sort of saying, I would prioritize the risk of injuries from getting lost. And personally, I would pick that as well. And then half of you said, oh, no, I would sort of prioritize the emotional consequences of boredom and frustration. Again, we have a bit more people who might focus on the risk of injury from falling versus the risk of emotional consequence. We hear often when we sort of recommend a walker and the client says, no, 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 that makes me look old. And then discharge destination, we have sort of a third, two thirds where people would prioritize the risk of injury from remaining in hospital over risks of injury returning home. And again, no right answer. Um, and what I am just trying to kind of highlight here is that risk assessment always involves values. All risk decisions involve choices and balance, and these choices and balancing act always involves values. And that's values about the desirable action to take and values about the desirable outcomes. And we are more likely to undertake tasks that fit within our own value base, and we are more likely to seek the outcomes that we value and desire, even if unconsciously. And so, again, going back to that balanced approach to risk where there are positive and negative consequences, both physical, emotional, and social, those are all valid consequences, but it's not really for us to prioritize what should be the focus. And that's where it needs to align with what does the client prioritize as being more important, the emotional consequences or the physical consequences? Again, that's not for us to decide. That's for them to kind of make those choices. Our part of the puzzle is ensuring that the conversation that we're supporting is balanced. So providing both of those information. And so I always kind of ask too, like, how many people hear their client come to them and say, or patients say, like, oh, help, I'm living at risk. Can you help me? I have never had a client say that to me. What they're doing is going about their life, participating in meaningful engagement in activities in their life. And this is from a study where it was people in their late 90s still living at home, trying to make those choices. So here's an example of Mrs. S, where she's talking about making my bed and acknowledges that it's an effort. I become tired and I risk losing my ability to stay balanced. So, increased risk for falls. And she acknowledges, yes, I could make my bed more simply, but she didn't want to give up on adding her bedspread as long as she felt she had the strength to do so. In her mind, and her values and beliefs, she was saying the prettiness of the addition of the bedspread outweighed for her the risks associated with falling because it allowed her to continue to direct her own actions according to her values and aesthetic desires. So, again, her sort of making those choices and deciding, you know what, I am going to prioritize the prettiness of my bedspread, you know. Well, that's just sort of, what that looks like in day to day. And so when we think about our values and how do we ensure that we're not skewing the conversation, because we also know from the literature on shared decision making that we have a propensity to kind of coerce knowingly or even unknowingly our clients into following through on recommendations that support our values. And so again, so kind of checking, are your values reflecting on, are your values showing up in the decisions and the recommendations that you make versus ensuring that you're supporting their values? Do you go into the situation with what's called a confirmation bias, which is like you're already going in with a conclusion on what should happen. And so then you're only taking in information that supports that. So another way of kind of reflecting on your values, are they impacting on some of the decisions or recommendations you're making, but also this concept of, the finite versus the infinite mindset. And I don't know if people have had a chance to read the information on this from Simon Sinek, but it's the idea that if we go in with a closed mind about what's happening, we will sort of see things as they are, not as what they could be. And if we can, versus going in with an infinite mindset, keeping it open, being curious, and you're able to be a bit more creative about the art of the possibility. Why is it also hard? Because we're also balancing a lot of tension. So on the one hand, the bioethic principles of we're trying to do good, do no harm. At the same time, we're trying to support the right to self-determination. We also have tensions around outcomes. Like on the one hand, we are hoping for the best for our patients, but at the same time, we actually have to support the worst. I often in these client scenarios are thinking about like, what is the minimum requirement of living that I have to support? Because I certainly want to support a lot more. Um, why is it also hard? Because people make decisions very differently. Based on our training, we're used to, attacking things in a very rational way, pros and cons. But we know, and we have seen, especially over, the pandemic, that people make decisions very differently. May make decisions emotionally, but also like holding space for those people who need to make decisions experientially. And are we providing the latitude for that? For instance, when have you learned the most? Has it been when it's been easy? No, you learn the most from when fail, make mistakes, where you're testing, you're learning. So are we preventing that opportunity for people? And then lastly, when we're kind of zooming into that last circle, we're dealing with people who have perhaps new onset of health concerns, so they have new limitations. And I ask you, when you have a new limitation, how do you know what your new boundary is? Are we putting a ceiling on people's potential? And again, I like this quote on the right, reinforcing the idea that they are still growing, that they're still learning, that they still have potential, that they're still in the pursuit of happiness, joy, and pleasure. And you only know what your new boundaries are unless you overshoot them. And I give kind of a quick example of when I had hip surgery. Now, the team didn't tell me this, but had they told me, there is no way, Heather, I was non-weight bearing for 6 weeks. And had they told me, Heather, there's no way you're going to be able to initially crutch 2 blocks. And had they told me that, I would have, said, yeah, thanks, but no thanks. And so I'm crutching the 2 blocks and then not well. And then I had to spend the rest of the weekend in bed. And so that helped me understand, like, oh, my new boundary is I can't crutch, 2 blocks. Like, so now it's like, okay, now let's just work on getting out of the house. Let's work up to 1 block. So again, when you have these new limitations, you need to kind of understand and experience what these new boundaries are. And this balanced approach to risk is also talking about this dignity of risk concept. And certainly there's the Nova Scotia Health Authority has really taken this to task, where they have a dignity of risk program where, going back to one of those original questions, is the dignity of risk means that we all have the right and to succeed and fail. And that's just kind of inherent of the day-to-day choices that we're making. And then the therapeutic risk taking is understanding there are actually benefits and reminding us that there are benefits from taking risks. So that's kind of the underpinning of what a balanced and broad approach to risk assessment is, why we may be skewed to one way of thinking, and how do we kind of broaden our thinking and approaching it. And one way to operationalize that approach is with what I helped develop, which is called the Living with Risk Decision Support approach. And it basically has 4 questions or 4 steps, where the first 2 are part of risk assessment and the last 2 are part of risk management. And so I'll just very quickly go through that approach. I'm just going to put, the website in the chat, where you can get an actual go through an e-module in more detail. So the first question is really, as I mentioned, is we're really trying to focus on what exactly is the older adult at risk of and who is concerned. So when I mentioned before that there are sort of, we as clinicians, we may be talking about four different things about risk. And this is where I really want us to kind of zero in on what exactly are we concerned about? Is it the falls? Is it the malnutrition? Is it the, medication mismanagement? What exactly is the safety concern? And then we're asking ourselves, is this new and different? We're also asking ourselves, so here is an example, the fall. We're also asking, in what context does this happen? Maybe a time of day, maybe a specific location, maybe a specific activity. So in this case, we have someone who's falling when they're getting up at night to go to the washroom, so with an activity. And then we want to ask ourselves, well, what could be the potential causes of this safety concern? Is it related to changes in their health or medical instability or medications, or is it related to sort of their values and beliefs? So in this example, we might be worried about poor balance, poor vision, polypharmacy. And then we're asking ourselves, what are the consequences, both positive and negative, and how are they related to health or quality of life? And in this example, we're concerned about this person might have a hip fracture because they have osteoporosis. So then that we've zeroed in on that the safety concern is falls, then we're asking ourselves, is this a low, medium, or high risk situation? And how do we do that? We look at two main factors. How likely is this safety concern to happen? And how severe are the consequences? So for instance, for this individual, they've already had a fall. So probably likely that if we don't change what's causing the fall, that they will have another one. And then how severe the consequences. As we know, you can fall and have no injury. You can fall and have kind of severe injury. So again, you need a bit more information about your individual, about how likely would it be for this individual to, perhaps in this case, we're worried about a hip fracture or other injury. So say we say moderate, and you take these two levels and you put this in this risk status matrix. So we had moderate and moderately likely. Oops. So that would put us in the middle. And if it's medium or high, we then might ask a few more questions to see, maybe does this make it higher risk or lower risk? How frequently is this happening? Are they falling daily? Is very different than a monthly versus yearly. How imminent are the consequences? So something like fires and falls, the consequences happen immediately versus something like malnutrition, where that might take longer for those consequences to appear. Do they have reliable, consistent support in place? That might reduce the risk to very low. And then what might escalate, the situation is that if there are other safety concerns happening, you might kind of then escalate it to high. So once we've identified what the safety concern is, ascertain what the level is, then we're asking ourselves, well, what can be done? First and foremost, again, we're going back to what does the older adult want and what is agreeable to them. So really understanding their goals, their preferences, and what's important to them. For those who are doing the 5Ms, what matters most, because that helps us frame the recommendations. But I go back to the first step where we kind of deconstruct it to kind of then help us give us some ideas of what we might recommend. So for the concern, are there ways that we can prevent the falls or minimize the frequency? What are some ways that we can adapt or modify the context? Again, the falls for our example is that it's happening at night with a certain activity. So it gives us some ideas of what we might be able to recommend. Who needs the intervention? So we may want to involve the caregiver and provide interventions. Gold standard of care for older adult is, yes, we're providing recommendations to the older adult, but how do we support the caregivers as well? And then we're really trying to say, well, why, in this case, why is this person falling? So we talked about poor balance. So we want to sort of address that impairment. We also want to acknowledge what strengths can we enhance or leverage, and then how do we adapt environments or activities, and then the consequence. So here's where we want to acknowledge, yes, there are both negative and positive consequences. Do we have an idea what those are? And the emotional, social, and physical consequences. So we tie all that together to have that conversation with our patient. And so what are some things to think about when we're having this conversation? So these clinical scenarios um, occur when there usually is a differences of opinion, because certainly if we make recommendations where they have some concerns and they agree to our recommendations, we're sort of all in agreement. So typically there's differences of opinions. The goal is to support agreement, not or sorry, understanding, promote understanding, and come to a shared understanding, not a shared agreement. We want to support those difficult conversations, focus on what matters most to help us, establish their priorities. Had an opportunity to ask older adults to say, look, clinicians want to have these tough conversations with you. How do you want to have those conversations and what information is important for you? And they certainly talk about, you know, you guys as clinicians, you tend to focus on what I can't do. So they wanted to remind us, there is a lot that they can do, and if that can be brought in. So again, when we're talking about this as a strength-based approach. How can we leverage their strengths and things that they can do? They absolutely said, I want to be involved in that shared decision making around, these important conversations that have a huge impact on their quality of life. They want to understand the rationales for some of the recommendations we're giving. And they said, please focus on the quality of my life, if that means sometimes that trumps, my safety. So again, just some things that older adults expressed. So just in summary, then, what is a balanced and broadened approach to risk assessment? As we covered, it is, yes, acknowledging there are physical consequences that can lead to significant harm, but also acknowledging that there are emotional and social consequences that may be preferred and prioritized by our clients. Again, it's a conversation that we have to have. There are negative consequences, but reminding ourselves there are also positive consequences, and a balanced approach requires us supporting conversations about both. Just a reminder that positive consequences can only be articulated by the older adult or their shared decision substitute decision maker, and that a broadened and balanced approach requires that shared decision making. This process that we're talking about has proven benefits for the older adult and feel engaged and heard, for the caregiver as well, for the clinician, where it has improved clinical thinking, decision making, the therapeutic relationship, and for the team in terms of ensuring that people are, it's structuring those conversations, it's leading to actions and supporting a comprehensive approach to care, but also addressing the risk. And that are some references, and happy to take any questions.
Thanks, Heather. We've had a couple of questions pop into the chat that I think there's a really good one here from Lori. She asks, where does insight come into the decision support approach? And then she also asks, how do you balance the caregiver's burden to accommodate the values and expectations of their loved one?
Yeah, so great questions. And certainly in these brief conversations, I've distilled it to very, a simple example to kind of demonstrate how the process works, where I know, these clinical scenarios that we might use this approach with are very complicated, are very individualized, cause a lot of moral distress for clinicians. And often, you'll see on the website, there's one of the worksheets is a coaching conversation. So certainly we're better able to kind of support our older adult in these conversations and their caregivers when we are able to debrief with, our managers or our colleagues. So absolutely want to preface that. And when I've used more complicated scenarios, people kind of then start arguing about the scenario. Well, that possibly couldn't happen, yet they were kind of amalgamation of the client. So then people get distracted by, the details of, the cases. So I appreciate, so insight is and certainly when I do the presentations, I love doing it with ethicists because they talk more eloquently about these topics and what we're struggling with as clinicians, but also kind of a neuropsychologist around the capacity assessment. Absolutely. Cognitive abilities kind of do play into it, how people are making decisions. But interestingly, there's a clinician who's doing a similar type but different decision support tool for long-term care. And in part of her work, she's kind of proven that people with dementia can still articulate their preferences. And the other thing that I used to speak a bit more about cognition because it does have an impact on how people make decisions and how people are able to follow through on the task required for the minimum requirement of living. But again, it's just it's hard to do it justice. But we what I do want to acknowledge is kind of going back to the decision making. Not all people use insight to make decisions. So, again, even with no cognitive impairment, you're still going to have to interact with people who may kind of make decisions emotionally and not using insight or judgment. Often I interact with people who I felt were in denial. And, is that stoicism? Is that, a cognitive impairment of lack of insight, or is it denial? And sometimes it's all three. So it's definitely very complicated. Some of the work that we sort of do as clinicians is kind of really try to zoom in and say, is this new and different? Is this how they would have always made decisions like this? To kind of more point towards if this isn't new and different, then that might be something we want to look into. And when we present with a neuropsychologist and organizing a capacity assessment around these kind of things, and I can certainly put into the chat, there's a great decision-making capacity assessment decision tool out of Alberta Health Services that can kind of also work through some of these decisions that we have to make. There's some times where that capacity assessment doesn't change the outcome. So again, I'm not doing I'm not answering or doing justice to your question, but just acknowledging that it's very challenging and that it requires you kind of, talking this through with your team. And how do you balance the caregiver's burden to accommodate the values and expectations? Exactly. That's not easy either. But I find that this approach, like what I worked you through in terms of like, how are your values impacting on these decisions, has been helpful for clinicians to work through with the caregivers, because I often, was pushing back. And that's kind of how I started this work, is that I had caregivers like say to me, you got to relocate my mom right now. And I'd say, why? And they'd say, well, they're living at risk. And you're like, well, what's the risk? And they're like, well, the house is dirty. And I'm like, well, we don't relocate people for a dirty house. You haven't seen mine. So, but what if the dirt is like mouse poop that's in the microwave that the person uses to heat up, their coffee or their food? So again, it's kind of working through and reminding them that, just like they get to make decisions that lead to negative outcomes, so can the family. It's a lot of anxiety. And that's why I kind of talk about that risk averse society. We're all more risk averse. And why do they feel like they own the outcome? There's so much guilt around that. And I can spend even longer time talking about why do we feel ownership in the outcome for decisions that other people are making. Like, and a good example is a very simple one is I want to be someone who flosses my teeth every day, but I don't. And every 6 months, I go to the hygienist and she's like, well, and the dentist just says, well, just floss the teeth you want to keep, you know? And so when I show up and he's got to remove my teeth, like after, 20, 30 years of not flossing, like he's not owning the outcome that I'm now losing my teeth. He's, provided these recommendations that I did or didn't follow through on. So again, it's really made me think about like, why do we feel we have ownership on some of these outcomes? And certainly family feel guilty as well. So again, not doing justice to answering that question, but it's very complex and certainly that's part of those conversations. That's hard to do in the emergency department where time there's a pressure and there's so much happening and so much unknown. So I kudos to you.
Thanks, Heather. I saw Stacy's hand for a second. Stacy, we're just going to head into break soon. What final comment from you? Did you want to add something?
Yeah, I was just going to add because my area of specialty is clinical decision making with
Yes,
persons with
yes.
dementia. The research says that individuals with dementia, even in the late stages of dementia, can express values and preferences in what they value in life. So it may not necessarily be around capacity to make a decision. But I mean, as gem nurses, I know you're really good at determining, like taking, physical cues and emotional cues and considering the perspectives of, say, care partners, other clinicians in the ED, and the person with dementia. Um, whether or not that's appropriate to go in such a full understanding of making decisions of care within the ED remains to be seen. But I think as nurses in the ED, you're used to advocating for the perspectives of those individuals and your patients in general, as well as the care partners when you can get it. So um, I feel like this we have a lot to learn from your approach. I've seen it like in the ED, watching gem nurses engage with individuals with dementia, and I think there's opportunity there to sort of maximize and think about what that means in other settings and sort of expand that approach. So I just want to say thanks to the nurses again.
Thanks, Stacy, and thank you for continuing to remind us. We're in the midst of Nursing Week and a wonderful opportunity to celebrate with you all. Heather, I really want to thank you. I know this is a passion project for you. You've done a lot of work in this area. This only scratches the surface. So thank you both for playing double duty today, but also for sharing your knowledge in this topic. We're going to take a break now. I've popped in the chat. When you come back, you're coming back to a different Zoom room. So take note of the Zoom link that you need to come back to. We're going to start right on the dot at 10:50. So take about 10 minutes, just refresh your coffee, and we'll see you back in the next Zoom room. Thank you so much to our presenters this morning.
I just wanted to say if anyone's having trouble still with their portal, stay on at break or lunch and we can get that sorted out for you.
Great. Thank you.